Hello everyone. Today in this session, we will learn about MEN syndrome and autoimmune polyglandular syndromes. Uh, to mention a few words about these topics, the first thing is that MEN syndrome and APS are mostly MCQ oriented questions. Most of the time, your NEET super specialty entrance questions would be based on MEN and APS syndrome. But in clinical practice, also, we often miss syndromic presentations very often. That's because we never lend an eye or a ear towards these syndromes. We never knew how much it is important to diagnose a syndrome, because by diagnosing a syndrome we are going to tell them that it's not only the particular disorder that they are having. They will also have some other disorders coming in their upcoming years. And secondly, we are going to watch be on a cautious front to diagnose the other disorders even before they come in very earlier stages. We may easily interfere in that management. And the third important thing is that by assigning them to a particular syndrome, we are assigning a risk to their family members also. So their family members can be very easily or very early diagnosed, and they can be treated accordingly. So these are all the very important points that we will have to know whenever we discuss about any sort of syndromes. Today, multiple endocrine neoplasia syndromes, the word literally means that there are multiple endocrine glands which are involved here. So at least there should be two or more endocrine tissues with neoplasms and in several members of the family. So you call it as multiple endocrine neoplasia. Okay, so this is the basic thing. So you have four different types of men. You have one, two, three, and four types. So we will see about the four different types of multiple endocrine neoplasia syndromes now. The first one to go about is multiple endocrine disease has predilection for tumors involving two or more endocrine glands, and there are four types. Almost all these syndromes are having an autosomal dominant transmission. They will have either a particular tumor suppressor gene which has gone for an inactivation, or there could be a proton gene that has gone for an activation. So either way, there will be enhanced tumorigenesis in these neuroendocrine tissues, and thereby they manifest with all these endocrine manifestations. Most of these syndromes will have a familial presidency. So at least one or two members of their family members will have at least one manifestations, because there is something called penetrance. If you are having a certain type of mutation, it is not mandatory that all these persons with the same level of mutation should have all the manifestations. The penetrance varies according to each and every disorders. For example, in a syndrome like MEN1 syndrome, you are having three manifestations. You are having hyperpara, pituitary adenoma, and you are having pheochromocytoma. If, for example, I'm just telling you for an example. If these three manifestations are there in a particular syndrome, all these three manifestations shall not be characteristically present in all the members who are harboring the same mutation. So the penetrance varies according to each and every syndromic presentation. The next thing is expressibility. Expressibility of a particular syndrome may also vary. For some patients, hyperpara may be very severe. For some patients, it will be very subtle. For some patients, that may not be hyperpara at all. So it usually, these two things make us usually give us a very confused clinical picture. But the basic thing is that even before onset of these symptoms, some family members may actually expire. So even there may not be any history at all. So around 20 to 30% of almost all the men syndrome, they will have a sporadic de novo mutation, but most of the time it is having a germline sort of mutation which is inherited through and through from the family. So there are around four types of men syndrome. The first one is MEN1 syndrome. Okay, so with respect to MEN1 syndrome, it is autosomal dominant mutation as very clearly known, and you have a MEN1 gene which is actually a tumor suppressor gene here. So it's a tumor suppressor gene which goes for an inactivation in chromosome 11q13. So the expressibility is around, usually the prevalence is around 2 to 20 per 1 lakh population. This is the general prevalence or incidence ratio of MEN syndrome. And in MEN syndrome, you will have to remember about the characteristic 3Ps. So from up to down, it would be pituitary adenoma. The second P is parathyroid hyperparathyroidism. It could be either a hyperplasia. Most probably it would be an hyperplasia only. And the third thing is pancreatic neuroendocrine tumor. So in MEN1 syndrome, always remember about three P's. So pituitary adenoma, parathyroid, and pancreatic neuroendocrine tumor. Of this parathyroid manifestation is most common in MEN1 syndrome. Around 100% of those who are harboring this mutation will definitely manifest these parathyroid manifestation, and that too will happen below 50 years of age. Within 50 years of age, they will have all the manifestations of MEN1 syndrome. Clear? So followed by this parathyroid thing, the second most common would be pancreatic neuroendocrine tumor. This is the second most common. There are various types of pancreatic neuroendocrine tumor in MEN1 syndrome. Okay. So in parathyroid hyperplasia, if you just look, more than more than adenoma, hyperplasia is more common. And usually these patients will have a young onset hyperparathyroidism. And PTH level, just because it is a hyperplasia, it may not be very higher. It may not be astronomically higher, like how it happens in a parathyroid carcinoma or a parathyroid adenoma, it may not be higher. And similarly, the calcium levels would be higher, but it will not be so higher. The symptoms also will not be as higher as in a parathyroid adenoma. If you just see any patients with a sporadic mutation, most of them would be female, and they will be mostly more than 50 years. And they will have parathyroid adenoma with high PTH levels and high calcium levels. So this picture will not be seen in those who are harboring MEN mutation with hyperparathyroidism. So all these features or characteristics of MEN1 related hyperparathyroidism. So they will have hyperplasia more than adenoma. Most of them will have a young onset hyperparathyroidism, and PTH level may not be astronomically higher. The calcium level would be subtle. It would be just high normal or high sometimes, but the symptoms may not be also that common. But they are at higher risk of nephrocalcinosis because of the chronically high normal or chronically elevated calcium level. They may manifest with nephrocalcinosis and osteitis fibrosa cystica, and they are at high risk for osteoporosis also. So even if you are doing a technetium system EB scan or ultrasound scan, these patients may not manifest with any clinical or radiological manifestations also, because there's no proper adenoma. Hyperplasia will not be that bigger also. So if you are doing a system, maybe all the parathyroids will be lit up. And if you are taking a ultrasound also, almost more or less there will be just a subtle enlargement of the parathyroid gland. That may not be very gross enlargement like an adenoma. Adenoma in MEN1 syndrome is very, very, very rare. Similarly, the carcinoma part is also very, very rare. So the parathyroid manifestation in MEN1 syndrome is usually diagnosed with serum calcium level, serum phosphorus level, and PTH level. Calcium will be high, phosphorus will be low, PTH would be inappropriately high for that particular calcium level. Whenever the calcium level rises, PTH should go for a feedback suppression. But instead, if you see the PTH on a higher end, or if it is high properly also, you will have to suspect hyperparathyroidism. Okay. And you will have to ask for the family history in these cases. If there is a recurrent family history of renal stones or a young onset hypertension in the family, or any infertility history in the family and all, then it's more in terms of MEN syndromes only. Okay. Similarly, how will you go and treat? The ideal treatment is based on 4 criteria, or 4 to 5 criteria we have to treat a hyperparathyroidism. The first thing is calcium level. If it is more than 12 milligram per dl, the total calcium level is very higher. It's consistently more than 12 milligrams per dl. Or if there is a renal manifestation, if there is a renal injury or renal involvement, which is secondary to the hypercalcemia. And the third thing is age. Age less than 50 years, definitely go ahead and go with surgery, because even lesser than 50 years, you are seeing a patient with a hyperparathyroidism, he has got years ahead. So definitely they will be at higher risk for osteoporosis and higher risk for fractures. So they have to be treated with surgery only. And any bone manifestations. So bone manifestations in form of any osteoporosis, osteopenia, fractures, or neuromuscular or musculoskeletal manifestations, if at all there, then all these are indications to go ahead with surgery. So what sorts of surgery we do here? Usually we go for near total parathyroidectomy. we go for near total parathyroidectomy. So here either we can use two ways. Way one is that we either go for complete removal of all these parathyroid glands, and we take a small tissue of the leftover parathyroid gland, we mince it, and we put it in the patient's non-dominant forearm. So that if there is again a higher level of PTH hormone, we can remove it from that particular forearm. Or else we can just leave we can take 3.5 parathyroid and we can leave half of the parathyroid again in the neck. Okay, this can be monitored by monitoring IPTH intraoperatively. Intraoperatively, if the IPTH level is less than or equal to 50% from the minimum from the first PTH level, then that value can be taken as positive and we can leave half of the remaining parathyroid gland in the neck. Okay, however, they have to be clinically monitored clinically as well as biochemically annually. If there is a spike, that parathyroid should also be removed. Okay. Even before that, if the level is subtly higher, if they are having hyperpara but no manifestations matches this particular criteria, then they can be managed with sinacalcet. Adequate hydration can be given. To prevent the bone resorption, we can give anti-resorptive agents to the patient. So, like we can give zoledronic acid or denosumab based on the renal function. The third important thing is we can give a calcium mimetic. So, this is sinacalcet. So, what sinacalcet does is that it will go and act on the calcium sensing receptor in your parathyroid gland. So, it will mimic itself as a calcium. So, whenever there is high levels of cinacalcet in your blood, it is not going to cause you high manifestations of hypercalcemia. But at the same time, it's going to tell your calcium sensing receptor that this is the calcium and it's going to bring down your PTH level at least to a certain extent. It may not respond in carcinoma, it may not respond in adenomas, but in certain hyperplastic conditions, it may still respond. So, in that condition, we can use medical management. Okay, so this is about hyperparathyroidism in MEN syndrome. So the most important thing that you will have to know is you're not going to have high levels of calcium, no high levels of PTH, no adenoma, and it's going to be young onset, no female male prediction. It's equally representable both in males as well as in females. The exact opposite thing happens in any sporadic mutation. Okay, and when are you going to treat? Usually, only the first 5 criteria is satisfied, you are going to treat. The calcium level should be higher than 12. Renal injury should be there. Age should be less than 50. And bone manifestation should be there. Neuromuscular, musculoskeletal manifestation should be there. And the ideal treatment modality would be to go for surgery. Surgery is either near total parathyroidectomy, either you are going to leave the remaining half of the parathyroid gland inside your neck, or going to remove it outside, mince it, put it in your non-dominant forearm. Sometimes it's even implanted in the neck also, somewhere near the strap muscles, so that it will be easy for removal if it is in subcutaneous plane. Okay, so these are all the manifestations, and if it is very lesser, then we are going to go ahead with the cinacalcet therapy and IV hydration, and you can even use anti-resorptive therapies. So next most common manifestation is pancreatic neuroendocrine tumor. Okay, with respect to pancreatic neuroendocrine tumor, most of the pancreatic neuroendocrine tumor would be non-secretory. It would be usually a non-functioning pancreatic polypeptide oma. Okay, so how is it even found out then? It's not functioning. Then how are you telling that there is a neuroendocrine tumor? Because in most of the cases, whenever it's more like an incidental oma, they would do a MRA or a HRCT or from some reason, for some other reason, and incidentally they will find out a neuroendocrine tumor litting up or sitting somewhere in the pancreatic bed or in the duodenum or in anywhere in the gastrointestinal walls. Sometimes until this neuroendocrine tumor goes for metastasis, it will be silent. It will not be secreting anything. So such non-functioning pancreatic polypeptidoma would be present in 22 to 55% of the total pancreatic neuroendocrine tumors. So if it is the case, then it has to be removed. If it is localized, it is somewhere inside, it's contained, then it can be removed and you can give a complete curative therapy. However, if there is metastasis, then the treatment will vary. We'll see about the treatment in coming sessions. Then the next most common among the functioning thing, the most commonly functioning would be gastrinoma. So gastrinoma is seen in around 50% of the cases with MEN syndrome. Those with PNET, those with pancreatic neuroendocrine tumor, around 30% to 50% will have pancreatic neuroendocrine tumor. Among them, if it is a functioning, around 50% of the total pancreatic neuroendocrine tumor would be gastronoma. And gastronoma is the most common functioning pancreatic neuroendocrine tumor. So, how are you going to identify it as gastronoma? The first and foremost important sign is that there is going to be excessive acid secretion. So, the patient will come to you again and again with recurrent gastritis. And sometimes this gastritis would be recalcitrant. They may not respond to the histamine blockers or PPIs, to any sort of antacid solutions. So it may not respond to any sort of anti-acid therapy at all. And when they are being subjected to IUGScopy, usually the ulcers would be seen in very atypical sites, not in the routine sites. So these are all certain red flag signs that is telling you that the patient is having acid secreting gastrinoma. So what you are going to do here, what you are going to do is that we will have to find out, mostly the most common site would be recurrent recalcitrant gastritis. So the most common site would be duodenal wall. It will be usually in the duodenal wall mucosa. That is the most common site. And most of the time it would be a unifocal, but since it is in a syndromic manifestation, by the time we diagnose, it may be multicentric and it would have entered even into metastasis also. If that is the case, if it is unifocal, very easy. You're going to do a proper endoscopic ultrasound and you're going for complete avulsion. Okay. Suppose if it has spread everywhere, it has gone to your liver, it is extensively spread, then we are going to do a surgery initially to reduce the tumor load, followed by some palliative therapies. For symptomatic management, you can give high doses of antihistaminic blockers as well as PPIs. High doses can be given. Okay. Sometimes, to a certain extent, octreotide and lanreotide was also used in certain cases. The third main thing, if there is a local metastasis, single metastasis, one or two metastasis in your liver, then right away you can go for radiofrequency ablation or hepatic artery embolization techniques. Okay, and in very resistant cases, if it is multicentric and it's completely inoperable, then in that cases you can either opt for chemotherapy. So the chemotherapy generally which are used in pancreatic neuroendocrine tumor would be 5-fluorouracil, streptozotocin, dacarbazine. So these are all the common chemotherapy that are being used for your pancreatic neuroendocrine tumor metastasis. And one important therapy is directed radionucleotide therapy. So you can go for yttrium or lutetium based radionucleotide therapy. So these are all the options that you have got for any gastronoma. If it is in a full swing, like if it has gone for a full blown metastasis and all, and if it is inoperable, you can use all these therapies. But the general thing would be to go for a proper localization. If it is there, then if it is single tumor, you have to go for a proper avulsion only. And what would be your investigation? So you will have to look into the fasting gastrin level. If it is more than 200 picogram per ml, then it is suggestive of gastrinoma. And before going in for fasting gastrin level, there are certain important criteria that you will have to do, because gastrin is also feedback oriented. So if the patient is already having severe achlorhydria, or the patient is under chronic PPA or antihistaminic therapies, or if the patient has underwent a surgery, or there is some gastric outlet obstruction happening, a small piece of your small bowel has been resected so that there's no feedback to inhibit your gastrin secretion, or if there is retained antrum alone so that it's not responding to feedback and starting to produce a lot of gastrin, then these are all certain indications where you will have to rule out. You'll have to rule out all these conditions before interpreting a gastrin level. And all the most in MEN1 syndrome, the main factor is that in MEN1 syndrome, already there will be hypercalcemia. This hypercalcemia will further increase your gastrin levels. So you will have to even control your hypercalcemia and then go for fasting gastrin level assessment. So this is about gastrin level. If the acid levels are torrentially higher, very, very higher, such that the complete GA system is tormented and is being imposed on malabsorption, then the patient may even manifest with diarrhea. So there may be diarrhea, steatorrhea, weight loss and all. which can happen in very, very resistant cases of gastronoma. And this syndrome is called as Solinger-Ellison syndrome. So you have gastronoma. If there is recurrent recalcitrance, recalcitrant level of gastrin, which is produced by a proper pancreatic neuroendocrine tumor, and it is very severe enough to cause excessive manifestations like diarrhea, steatorrhea, and weight loss, then it is Solinger-Ellison syndrome. Okay, so this is about gastronoma. Moving on to the next session, you will have to know about the next secretory tumor. The next most common secreting tumor would be insulinomas. Okay. I'll just finish it off and then go there. It is insulinoma. So it is second most common. Around 20% of these patients, approximately 10 to 30% will have insulinomas. And it's the second most common. And usually the insulinomas tend to happen in the pancreatic bed. So you could see insulinoma sitting in the bed only. And malignancy is again not that uncommon in insulinomas. How do we even diagnose an insulinoma? Usually whenever the patient comes to you with excessive weight gain along with recurrent episodes of hypoglycemia and a background of hypercalcemia, then you will have to suspect more in terms of insulinoma. To diagnose something, you will have to catch the patient right in the act. So you have to get the patient right when he is having that hypoglycemia episode. So whenever he is actually throwing up that hypoglycemia episode, in that episode, you will have to measure the patient's blood glucose. The patient's blood glucose generally, any level less than 70 is hypoglycemia. But here for the measurement, we will usually take less than or equal to 55 milligram per dl. So when the sugar levels are lower, for that sugar levels, your insulin level should be completely undetectable. But despite that, insulin is detectable. C-peptide is also high. That means that there is still some endogenous secretion of this insulin. Along with it, the proinsulin, if it is higher, it means that it is coming endogenously more on a background of absent sulfonylurea and on a background of absent autoimmune insulin syndrome. Insulin antibody syndrome shouldn't be there. So if that is the case, and usually in insulinomas, the levels would be torrentially higher. And the proinsulin to insulin ratio would be also higher because it is coming from the tumor. And the tumor will produce a lot of proinsulin, such that the enzyme which is needed for the cleavage, proteolytic cleavage to form an active insulin is saturated. So if that is the condition, then proinsulin level to insulin level will be very higher. It indicates that it is a tumor. Okay. So once it is diagnosed to be of insulinoma, the next step would be to do a proper functional imaging. Okay, insulinomas, usually the ideal functional imaging that we generally what you see, you will have to see for a CT MRI for the extent of the spread and the local infiltrations and everything. This would be done for any surgery. But to initially find out whether the insulinoma is unicentric or multicentric or if some metastasis has happened or not, you will have to go for extending based scans. Okay, so that is the best scan. Nowadays we have gallium dotanac scans and dotatate scans, so a lot of other scans are also available. So they are going to tell you wherever the neuroendocrine tumors are there, wherever the SSTR receptors, somatostatin receptors are expressed, this scan is going to target on them. Okay, so it's going to sit on that particular area. So it will tell you right there whether it is in pancreas, whether it is in liver, or it has spread somewhere else. It is situated in only one region of pancreas, in multiple regions. Those things can be derived from these scans. And again, for the local infiltration and spread and all, you can go ahead and do a proper CT and MRI, and you can diagnose accordingly. Even insulinoma has to be treated with surgery only. So gastronoma surgery, insulinoma surgery, anything which is producing anything should be treated with surgery only. Okay. The next most common would be glucagonoma. Less than 3% only will have glucagonoma. It's bit very rarer in men syndromes. But if it happens, there are certain characteristic features in glucagonoma, right? So what are the characteristic features? So usually there is something called necrolytic migratory erythema, which can happen in high levels of glucagonoma. And in glucagonoma, it's more of a counter-regulatory hormone. And along with glucagon, a lot of other peptides will also be released. You know about the GLP, GAP, and a lot of other peptides. They break from the glucagon molecule only. So they are coming from the precursors of the glucagon molecule. So obviously, a lot of other manifestations would be there. The patient may present with anemia, severe depression, diarrhea, anorexia, weight loss, and fasting hyperglycemia is also one characteristic feature. Sometimes they manifest with cheilitis, angular stomatitis also. So this is how glucagonoma will characteristically present, but more commonly it will not be uh, producing any changes at all. It will be a lot of the time it would be non-functioning sort of manifestations only. So moving on to the next thing, it is VIP. VIPoma less than 1% only. It's very, very, very rare. And in VIPoma, there is a characteristic syndrome called Werner Morrison syndrome. We also call it as VADA syndrome, VDHA, VADA syndrome. So you have watery diarrhea, hypokalemia, and acidosis. So here vasointestinal polypeptide will be released in plenty. So what happens is that your intestine would be literally entering into a secretory sort of diarrhea. So the ideal treatment of choice in glucagonoma, insulinoma, VIPoma, wherever it is secreting something would be to stop the secretion. So the treatment would be either to give a somatostatin analog. So the ideal thing is octreotide. If the patient is in crisis, such as in carcinoid crisis or some features like that, it would be an octreotide infusion. However, if the patient is otherwise okay, hemodynamically stable, then we can give octreotide depots. Okay, so right now there is a new octreotide depot, octreotide-like depot, which is called as lanreotide. So that is also being used in all these conditions. Okay, so this is about the pancreatic neuroendocrine tumors in MEN1 syndrome. So moving on to the third important part, which is actually pituitary adenoma. The third P, pituitary adenoma. The pituitary adenoma, most common would be prolactinoma only. Okay, so usually pituitary adenoma in MEN1 syndrome would be not responding to a conventional therapy. If it is prolactinoma, if level goes more than 200, it's macro, and less than 200 it would be usually a microadenoma. But in prolactinoma, usually they respond very well to dopamine agonists. I have told you in the pituitary chapter that prolactinoma is the only condition which can be treated with a drug. Now, other all pituitary tumors, you will have to right away go with the surgery. But in prolactinoma, in MEN1 syndrome, usually it will respond, but very commonly it may not respond with treatment also, oral medications also. It may be dopamine resistant also. So mostly in MEN1 syndrome, if you see, very high doses of dopamine agonist would be given. And they will develop dopamine agonist. They will be developing resistance towards dopamine agonist also. So in that case, aggressive surgeries would have been needed, and even radiation would be an ideal choice after surgery in these conditions. So apart from that, you may even have acromegaly and Cushing's, which could be a direct pituitary adenoma inflicted condition, or very rarely it can happen with your uh, pancreatic neuroendocrine tumors, paraneoplastic manifestation. If you see, you are getting carcinoid syndromes and all, right. In carcinoid syndrome, sometimes they do release ERH, they do release ACTH, and they do release GHRH. In all these conditions, because of the release of these uh, hormones as a paraneoplastic manifestations of these tumors, these hormones tend to act on your pituitary, and this pituitary enters into a state of hyperplasia. And because of that, they manifest with all those features. So otherwise, it is okay. Okay. So the next, so we'll see about it. To diagnose that a patient is having MEN syndrome, you should have at least one out of these three criteria. The first thing is that patient should have clinical features. Two or more of the associated tumor should be there. For example, there should be a hyperparaevidence calcium, there should be increased gastrin levels along with their clinical symptoms. At least two symptoms are there, then think more in terms of a MEN syndrome. Familial pattern of one of the associated tumor. See, brother should have or father should have, and again they should have a hyperpara. So two patients in the same family, in the same first degree relative is having an hyperpara. So think more in terms of uh, MEN syndrome. Genetic analysis, a germline mutations in an individual who may be clinically affected or asymptomatic. Then also think more in terms of it's 11q13. The gene name is menin gene, which is a tumor suppressor gene. You will have to know about the nuts and two-hit hypothesis. Usually, there will be it's an autosomal dominant transmission. So mostly there is a condition called loss of heterozygosity. See, you will have two genes, and usually what happens is that these genes would be having codons. So one particular codon would be affected. Okay, one particular gene would be affected. The entire gene, one particular area alone, exon or whatever it is, that is only affected. Simultaneously, here the another functioning exon would be affected. So this would be germline mutation. The other one is somatic mutation, which has happened right after the birth. So this is two-hit hypothesis. This is what you call it as Matson's two-hit hypothesis because of the heterozygosity. So you have a loss of heterozygosity. This is called as heterozygous mutation. The same mutation, if it is there, then you can call it as homozygous mutation. You have two different separate mutations, which is going to affect the function of that particular protein. So what happens finally? The tumor suppressor gene, menin, may not be functioning. As a result, there will be enhanced tumorigenesis. Okay, so this happens in MEN1 syndrome. Okay, the age of onset is as early as 5, but it can manifest until 81 years. So remember about the three P's. We have parathyroid, pituitary, and pancreas. I have told you about it in detail. Parathyroid, usually it would be hyperplasia in MEN syndrome, not adenoma. And pancreatic tumor, the most common would be gastronoma, followed by insulinoma. And overall, the most common thing would be non-functioning pancreatic polypeptidoma, glucagonoma, and VIPoma. Among the pituitary adenoma, you may have prolactinoma, somatotropinoma, carcinoma, and non-functioning also. And what are the other associated tumors usually you have? You will have to remember about carcinoids. Foregut carcinoids. Foregut matlab something starting from your neck until your second portion of your duodenum. So you will have mediastinal thymic carcinoid, bronchial carcinoid, gastric carcinoid, duodenal carcinoid, everything. So any sort of carcinoid manifestations can be present in the tumor. This is one thing. These are the other manifestations. The patient may present with lipomas, collagenomas. These lipomas, collagenomas can be subcutaneous or visceral. So if it is subcutaneous, very well, it's okay. But if it is visceral, this may lead to obstructive symptoms. The patient may present with megalocolon sort of manifestations. Patient may have constipation, diarrhea, other obstructive manifestations, etc. And apart from that, very, very rarely they may present with adrenocortical tumors also. Adala, pheochromocytoma is also quite common. So you have adrenocortical tumor, pheo. You have all these carcinoid tumors like bronchopulmonary net, thymic net, gastric net, lipoma, angiofibroma, collagenoma, and meningiomas also to a certain extent. So these are all the common manifestations in any case of MEN1 syndrome. Okay, just remember about the three P's: parathyroid, pituitary, parathyroid, and pancreas. Okay, in pituitary, most common is prolactinoma. In parathyroid, it is hyperplasia. And in pancreas, it is mostly non-functioning, followed among functioning, gastronoma is most common. And next, you will have to remember about foregut carcinoids. In the foregut carcinoid, you will have to know about the basic difference in male and female. If it is male, they are more prone to have mediastinal carcinoids, thymic carcinoids, which would be more aggressive to manage. Whereas in female, usually they end up having bronchial carcinoids, which is easy to manage. Okay, lipoma, collagenomas, adrenocortical tumors, and pheochromocytoma can also be a manifestation in MEN1 syndrome. So the same thing that I have told you. Hyperparathyroidism will be usually mild. You will have osteitis fibrosis, nephrocalcinosis. They usually have a younger age of onset compared to 55 years if it is sporadic mutation, equal male to female compared to high female incidence in sporadic mutations. And there is a separate entity. Patient may harbor MEN1 mutation, but they may have only isolated hyperpara. They won't have the other manifestation in MEN1. So this condition is called as familial isolated hyperparathyroidism. Their next subsequent generation will only have hyperparathyroidism. The preoperative, you can go for an ultrasound with technician system maybe, but it may not be of any benefit. I told you because all will be enlarged, all will go for an hyperplasia. It may not be of any benefit. The minimal invasive parathyroidectomy is not recommended because almost all four glands are involved. If it is adenoma, minimally assistive surgeries you can do. But if it is hyperplasia, all four glands are involved. So you will have to go for a gross surgery. You will have to open, remove all four only. Calcium mimetics can be used whenever there is a contraindication to surgery or the patient have unsatisfied picture. They are not satisfied with the different surgical criteria. Surgical criteria is not satisfied, then you can go with calcium mimetics. Similarly, the pancreatic neuroendocrine tumor, younger age of onset, and usually the non-functional would be more common, but with variable incidence. Sometimes it would be just 20% in certain ethnicity, whereas in other ethnicities, around 55%. The most common would be gastronomas. I told you about Swollen syndrome, diarrhea and steatorrhea, etc. More than 50% of neuroendocrine tumors in men 1 and 20% with gastrinomas will also have men 1. Okay, so what are all the scans that you're going to do? Endoscopic. Among them, endoscopic ultrasonography is the best thing. CT MRI can be done. Selective abdominal angiography can also be done. Venous sampling can be done. And somatostatin receptor scintigraphy, which is usually the gallium totonic scans and everything. So, what is this venous sampling that you do? Sometimes what they do is that they directly enter into that. Sometimes what does a CT or MRI show you? It will show you that there is some tumor there, but it's not going to tell you whether it is gastrin secreting tumor or not. In such scenarios, what you can do is that you can actually go for a selective abdominal angiography. You can channelize that particular vessel with a small stent. Okay, and you can inject calcium inside. When you are giving adequate calcium into that particular vein, if it is a tumor which is secreting gastrin, it will increase the gastrin secretion. This gastrin sample can be taken from that particular vessel. And if it is torrentially high, then you can very well label it as gastrinoma. So that is a thing behind venous sampling. Okay. So the goal of surgery is to reduce the risk of distant metastatic disease and improve the survival. So this is very important. Survival in men 1 patients with gastrinoma, if it is less than 2.5 centimeters, 100% at 15 years. But after 15 years, if the metastatic disease is present, then the survival rate usually comes down. Okay. And surgery for gastrinomas is recommended. If it is more than 2 to 2.5, we will definitely go ahead with surgery only. Okay. Disseminated gastrinomas, I told you earlier, you're going to treat with chemotherapies like streptozotocin, 5-fluorouracil, octreotide, lanreotide. You can give internal radiation therapy. So I told you about the yttrium and lutetium-based radiation therapy. You can go for a radio frequency ablation if there is a single tumor or metastasis in the liver, or PRRT is also a form of internal radiation therapy only. You can go for hepatic artery embolization. You can even use interferon therapy also. This is about gastrinomas and all the advanced therapies. Kindly read between the lines, because usually in these sort of syndromes, there could be certain conceptual based questions that can be asked. So the questions can be like that. In gastrinomas, which of the following is true? So they can give you something from inside. The survival rate is this much, and venous sampling can be done in these many patients, and it's going to give you a proper diagnosis. Something in between the lines you will have to know. So in any syndrome, if they're asking you something about gastronoma, you will have to at least have some basic points about gastronoma to tell you something. Okay, certain symptoms has to be remembered. See, if you're having gastronoma, if the patient comes to you with all these gastric and peptic diseases, and you're giving PPIs, and patient is not responding, suddenly this thing should come to your mind. Gastronoma should come to your mind. At least you will have to rule out those possibilities. And if gastronoma automatically comes to your mind, you'll automatically search for the other manifestations also. You'll ask the patient, is there any surgery being done, or if you're, are you having any hypercalcemia like features, like renal stones, it is there or not, bone pain there or not, any fractures in the previous past or not. So that only if you have a basic understanding of how a gastronoma functions, you can correlate it with some syndrome. So that is why I'm reading through the line. All these are very, very characteristic, important features of gastronoma. Okay. So moving on to the insulinoma, I told you already, it's 10 to 20%. 20% only will have. They may present with hypoglycemia symptoms. Okay. So weight gain is one characteristic symptom, because to counteract hypoglycemia, they will be go on eating. Okay, so weakness, headache, sweating, faintness, seizures, everything can come. But what they will do, they will compensate it by eating more and more and more. Okay, so supervised 72 hours fasting test can be done. In the fasting, if the sugar levels are very low, and for the corresponding glucose levels, if you see the patient's insulin levels high proinsulin, high insulin, high septate, in absence of antibodies and in absence of sulfonylureas, you will have to suspect more in terms of insulinoma. So how to preoperatively localize? You can go for the same localization that we have asked in gastronoma. So once it is localized, to confirm, you can go for a hepatic venous sampling. The medical treatment until the surgery would be frequent carbohydrate meal and diazoxide or octreotide. Okay, but it may not be always successful, because the tumor will not respond to the medical treatment always. It goes on spreading. Okay, the surgical treatment would be the ideal thing of choice. If it has spread, again the same treatment that we have used in gastronomas can be used here also. Okay, Moving on to glucagonoma, these are all the characteristic features of glucagonoma. You may present with weight loss, anemia, stomatitis, necrolytic, migratory erythema. But usually this would be absent. If they are present, it will be very easy to diagnose. However, usually it would be absent. Again, surgery is the treatment of choice. And 80% in glucagonoma presents with metastasis at the time of diagnosis. Again, the treatment is same level of treatment. With respect to VIPomas, I told you about VADA syndrome and Werner Morrison syndrome. You will have watery diarrhea, hypokalemia, achlorhydria. Okay, so you can before assigning this condition to secretory carcinoid, we will have to rule out laxative and diuretic abuse. Only then we can assign this symptoms to a VIPoma. Surgical management is mostly done. Okay, and unresectable tumors, same level of treatment that you have used for the other neuroendocrine tumors. So this is very important. PPOMAs, which are non-functioning pancreatic polypeptidomas. So same thing, like endoscopic ultrasound would be the most sensitive method. SRS is most reliable. Again, the management is very, very controversial. Okay, most of the surgical oncologists, they prefer going ahead with surgery because we don't know which tumor will go for a rapid spread and all. So the ideal thing is to undertake surgery irrespective of the tumor size if it is non-functioning. Non-functioning indicates that it is dedifferentiated. So definitely there is a very high risk that it will metastasize. So only 50 to 60% who are treated surgically will survive more than 5 years. So since it's not secretory, sometimes they may not respond to a routine chemotherapy. So in those, we will have to use TKIs. So you can use mTOR inhibitors, TKIs and all. So that has been used. So GHRomas, GHRH secreting bronchial carcinoid, pancreatic carcinoid, small intestine carcinoids can produce conditions similar to acromegaly. Okay. So somatostatomas can also be seen in MEN1 syndrome. Since somatostatin, what does it do? It will inhibit almost all the secretions, right? It will inhibit your insulin, it will be inhibiting glucagon, everything will be inhibited, but insulin will be inhibited more than glucagon. So hyperglycemia would be a manifestation. Gallbladder motility will be reduced, cholelithiasis would be there. It will inhibit acid secretion, so low acid output. It will inhibit all the exocrine enzymes also. So steatorrhea, diarrhea, abdominal pain, anemia, and weight loss would be there. So these are all the manifestations of somatostatinoma. Around 75% of the pituitary tumor in MEN syndrome are micro, and usually females would be affected in male. Macro would be more common in male. This is because in females, a microprolactinoma can be easily diagnosed because they will have menstrual irregularities and they come to a notice of a doctor very earlier. Whereas in male, they never present with any manifestation, no galactoria, nothing. Only at the fag end, they may present with infertility. Okay, that time, mostly this microadenoma would have progressed to a macroadenoma. That is why macro is more commonly in male. It doesn't mean that the tumor has a higher replicating tendency in male. The diagnosis will be delayed in male. By the time they reach the doctor, it would be macro. Okay, 60% would be prolactin, GH, ACTH. Even non-functioning pituitary adenomas are also very common. And carcinoid tumor, more than 3%, they will have bronchial GI tract pancreas or thymic carcinoid. And as I told you earlier, bronchial carcinoid is most common in women with good prognosis. Thymic or mediastinal carcinoid is more common in male and it's very aggressive. So meningiomas can happen in less than 10% of patients. You may even have neurofibromatosis like features. So ependymomas, schwannomas can also be there. Okay, lipoma around 30% will have. This could be in visceral, pleural, pericardial areas also. Cholangiomas, it's a varying incidence, and usually, if a relative of a MEN1 patient has cholangionoma, it is strongly indicative that he is going to exhibit some feature of MEN1 syndrome. So, it is a pre-symptomatic diagnosis in relatives. So, if they are having multiple cholangionoma, ask the history of MEN1 syndrome in any of their family members. You just ask them. So when will you do genetic analysis? You have an index case with two or more men-like feature, definitely you will have to do. And once it is done, any asymptomatic or symptomatic first degree relative has to be done. Okay. Anyone with atypical MEN1 feature also has to undergo a MEN1 mutation. Okay. And MEN1 mutation is very ideal if you are taking it within the first 10 years of your life. And the screening for all these manifestations, once the genetic test is positive, you will have to screen all these mutations until their lifetime. Because until 90 years, all these one by one may still manifest. So slow screening and manifestation is of utmost importance. So what are all the tests that you will use for screening? So generally in parathyroid, you will use calcium and PTH. Will you use any imaging test for screening purpose? No. Only if it is high, then we will go for imaging. And with respect to gastronoma, insulinoma, and other pancreatic endocrine, neuroendocrine tumor, for gastrin, we will go for a fasting gastrin level. And insulinoma, fasting glucose and insulin can be used for screening purpose. Okay. If they are symptomatic, then you can go for supervised fast. Okay. And other pancreatic neuroendocrine tumor, chromogranin A or pancreatic polypeptide can be done. And to rule out the possibility of non-functioning pancreatic peptidoma, you will have to ask for MRI CT or endoscopic ultrasound annually. So for pituitary, prolactin and IGF-1 is a mandatory thing. And for adrenal, usually we don't see anything. We do a MRI and CT for pancreatic polypeptidoma detection. That time only we look into the adrenals also. For carcinoid, generally if they have symptoms only we usually see. Otherwise in the same CT and MRI, we generally go for a screening CT and MRI. And in that we see whether there is any carcinoid manifestations also. So the ideal thing is go for calcium PTH yearly once. And gastrin and insulin levels, chromogranin levels, and pancreatic polypeptide yearly once. Prolactin also. So these are all the things that you will have to do yearly once. Imaging, depending on their initial appearance, whether it's there or not, based on that annually we will see. Once it is not that frequently seen, then we make it once in 3 years. Initially, it's annually, then we make it once in 3 years. So this is how we actually have to screen any patient with MEN1 syndrome. So this is about MEN1 syndrome. Only the MEN1 syndrome would be very exhaustive, but a lot of questions can be asked in MEN1 syndrome. And even clinically, we have seen a lot of MEN1 syndrome in our residency. People may go to a urologist for a recurrent renal calculi again and again, again and again. They will be operating, they'll be undergoing lithotomy and all those procedures, but they would have never done a calcium phosphorus levels at all. So in this, randomly, if you go there, we see calcium phosphorus level and we do that, we pick up a lot of hyperpara cases. Usually they will have a strong family history of renal stone. And if we evaluate further, then we'll get to know that they are having MEN syndrome. So it is not that rare. It is a bit common. Only the index of suspicion should be very higher. Okay. So moving on to the next part, which is MEN2 syndrome. So MEN2 syndrome, when one is actually tumor suppressor gene mutation. So you have a tumor suppressor gene which is inactivated. Whereas MEN2 is also autosomal dominant, but it is a red proto-oncogene mutation. So it is a proto-oncogene mutation. So here you have a oncogene, and this goes for an activating sort of mutation. So in men, you have two types. You have MEN2A and you have MEN2B. Okay, so generally the MEN2 syndromes are called as Sippel syndrome. The MEN2B is otherwise called MEN3 syndrome. There's no separate MEN3. MEN2B is otherwise called as MEN3 syndrome. The common denominator in these two is FEO and medullary thyroid cancer. So they are notorious to cause medullary thyroid cancer and FEO. Okay. So you have, usually I will mention the first medulla of adrenal, okay, just for easy remembrance purpose. So you have two M. One is medulla of adrenal, the other one is medullary thyroid cancer. So in 2A, you will have 2M plus 1P, which is hyperparathyroidism. So you have hyperparathyroidism. Here you have 6 M's. So apart from these 2 M's, you will have other 4 more M's, which is marfanoid habitus, medullated corneal fibers. You have megacolon. And you may have mucosal neuroma. So you may have medulla of adrenal, which is pheochromocytoma or medullary thyroid carcinoma. Apart from that, we'll have 4 more M's. Marfanoid habitus, medullated corneal fiber, megacolon, and mucosal neuroma. Whereas here, you will have 2 M and 1 P. You will have hyperparathyroidism. Okay. So the one characteristic point that we will have to remember in MEN syndromes is that it's about something called codons. So in MEN syndrome, apart from the red proto-oncogene mutation, there are certain codons which will tell you whether it is going to MEN2 syndrome or MEN3 syndrome. So usually in MEN2 syndrome, the codons would be in 600s. Whereas in MEN3 syndrome, the codons would be usually 900s and 800s. Okay, so it would be 900s and 800s. So why is it very important? Because men 2B, the MTC, the medullary thyroid cancer in men 2B would be usually very, very aggressive. Metastatic rate would be very, very, very higher in men 2B syndrome. So if any child is being born to a parent with family history of men 2B syndrome, or if the parents, anyone test positive for men 2B codon, right, within 1 year, ideally within less than 1 month, they will have to undergo a total thyroidectomy to just completely eliminate the possibility of medullary thyroid cancer in them. So that is how important it is. So that is why we will have to know about the codons and all. We will see about the codons now. So in men too, yeah, again you have small, small subdivisions and all. You have something called familial medullary thyroid cancer. How is a familiary isolated hyperparathyroidism with MEN1 mutation. Similarly, you have familial medullary thyroid cancer. So usually in familial medullary thyroid cancer, only the medullary thyroid cancer would be there. There won't be any hyperpara, there won't be any fever at all. Only medullary thyroid would be running through the family. They may have a red proto-oncogene mutation. The second thing is about MEN2A along with cutaneous lichen amyloidosis. And you have yet another thing, MEN2A with Hirschsprung disease. So here the particular segment of your colon would be completely aganglionic. So they will go for a mega colon sort of dilatation. So that can happen with Hirschsprung disease. Okay. So this is about MEN2 syndrome. So MEN2 is generally called Sippel syndrome. MEN2A is more common than MEN2B. Okay. It's most common among MEN2. And the red proto-oncogene, usually it encodes a tyrosine kinase receptor. So what happens is that it's going to increase your tyrosine kinase activity. So medullary thyroid cancer in men syndrome would be most common. In both, it's very common. More than 1 centimeter of medullary thyroid cancer is definitely associated with distant mens. Okay, pheochromocytoma would be manifested in 50% of all the men syndromes, and it usually would be bilateral, and it would be epinephrine more than norepinephrine secretion. Metastasis is not common, and it will be very, very rarely extraadrenal and very, very rarely malignant. So it is a very good thing. So usually remember the mnemonic, men always obey rules. So if you want to put a rule to pheochromocytoma, what you will do? You will tell the pheochromocytoma to stay within your adrenal. Okay, stay within the adrenal. Don't go outside the adrenal. So it will be usually bilateral and it will be usually intra-adrenal. Secrete proper epinephrine is what we do. So it will be secreting more epinephrine than your norepinephrine. Only epinephrine will be there. Don't go for a metastasis, we will tell. So no malignancy, no metastasis. And no paraganglioma also. Only it will be staying. So usually the pheochromocytoma in MEN2 syndromes would be always obeying the rules. Hyperparathyroidism comes in around 20% of patients, usually it will be 30 to 40 decade, hyperplasia and rarely adenoma, just like in any MEN syndrome. I told you about the subvariants, familial medullary thyroid cancer, MEN2A with cutaneous lichen amyloidosis, and MEN2A with Hirschsprung disease. So this is cutaneous lichen amyloidosis. This is how it will be usually looked. Usually it's common in upper back, but it can be seen in your arms, legs, everywhere. But usually it is seen in your upper back. Okay. So yeah, familial medullary thyroid cancer, only medullary thyroid cancer would be there. There wouldn't be any MTC, no FEO also. This is about men 2B. I told you about the 6Ms. So medullary thyroid cancer in men 2B would be more aggressive, and metastasis will start even before 1 year of birth. Okay, so pheochromocytoma again will be like a men 2A, and mucosal neuroma would be there. So it could come in your eyelid, it could be coming in your tip of tongue or base of tongue or GI tract. And if it is in the GI tract, it's going to cause intermittent diarrhea and constipation. And marfanoid habitus would be there, medullated corneal fibers would be there, and megacolon would be there. Okay, so these are all the manifestations of MEN 2B syndrome. So what you see here is a medullated corneal fiber. So this is seen in your here, this portion. Okay, so Usually, men to A, I told you about the codon, so usually it will be in 600s. Men to B, around 95% of the codons would be 900 and 800. The most important thing is 619. Here, the most important codon is 634. Just you remember these two numbers. If you see any patient with this number, definitely they have to undergo surgery within one month of birth. So 918, 883, 922, less than 1 month of birth, go ahead with surgery with central link dissection. Okay. If it is the other codons, then until 6 years of age, you have got adequate time to go for surgery. Even if it is familiar medullary thyroid cancer, you can wait even until 10 years of age. Until then, you will have to go for annual or a biannual calcitonin disease. So this is the chart which is given in your Harrison's when to go ahead with surgery, what sort of mutations. Basic thing that you will have to know is that whenever there's 918, 883, the patient is at very, 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 very higher risk, followed by 883 and 634, second highest risk. Other all codon, even lesser risk. So based on that, if you see this particular mutation, go ahead with the red mutation immediately within 1 year. Go ahead with the immediate measurement of calcitonin and NIC within 6 months, and let's go for a prophylactic thyroidectomy less than 1 month. Okay, and by 11 years, we will have to screen those patients for pheochromocytoma. So all these, when the risk goes a bit lesser, until 3 years, you have got time. But again, you will have to screen the patient for pheochromocytoma. If they are having very, very lesser risk, then pheochromocytoma can be screened by 16 years of age. Okay, so this is how you will have to screen the patient and what sort of mutation they have. So MTC, usually it's a non-symptomatic only. Usually you will be diagnosing MTC with a palpable mass in neck. The patient may manifest with symptoms of just pressure effects could be there. Very rarely due to the calcitonin effects, there could be a diarrhea also. So high serotonin, along with calcitonin, you may have serotonin and prostaglandins. Because of that, they may manifest with flushing-like features and diarrhea. If it is a sometime the medullary thyroid cancer may produce ACTH. So they may manifest with Cushing syndrome also. So to call a hypercalcitonemia, you have to have more than 90 picogram per ml even at basal state. When you use stimulation test and all, it should go even higher. So you go for neck ultrasonography with FNAC. PET is being used to look into for meds only. So aggressive clinical course, usually death would be there in 10% of patients. The death usually is due to the obstructive features, and sometimes it may be due to the torrential bleed, which is caused by the erosion of the blood vessels. So that would be the most common cause of death. So in any case of medullary thyroid cancer, the ideal thing would be to go for a total thyroidectomy. Even if it is less than 1 centimeter, go for complete total thyroidectomy along with central lung dissection. If central neck nodes are involved, again, the next level of node should also be empirically taken along with this central neck nodes. So go for lateral neck dissection. If there is a local mets or if the tumor size has gone more than 1 centimeter, go for lateral selective neck dissection also. So if there is local mets, will you treat, this is a thyroid cancer, will you treat the patient with thyroid suppression? No, because it is not a differentiated thyroid cancer. It is coming from parafollicular cells or C cells. So it's not going to respond to your iodine therapy. It is not going to respond to your TSH suppression. So what you are going to do is first thing is surgery followed by external beam radiotherapy. And if it is very, very extensive, then we can go for chemotherapy, ACVD regimen and tyrosine kinase you can give. Right now market, we have antitinib, cabozantinib and selpercatinib. I have told you about it in MTC, in thyroid cancers. Moving on to FEO, what you will do is that you will go for a urinary basal metanephrines. Positive, then go for a local scan. And it's very, very important in patients who are pregnant because it may be completely non-secretory. The patient would be completely not having any symptoms at all, but it will increase the risk of death during the childbirth because that time, because of the increased intra-abdominal pressure, the tumor may leak all these catecholamines outside, and the patient may land up with torrential crisis, hypertensive crisis, or it could be hypotensive crisis, or sometimes to the extent of bleed, and the patient may die. So it's very important. If they are having a family history, definitely they have to be screened. And if they turn out positive in pregnancy, second trimester, we'll have to remove the tumor. So that is about it. Okay. So this is MEN 3. MEN 2B is otherwise called as 3. We have MEN 4 also, which is associated with CDKN1B mutation, chromosome 12. So here you have parathyroid adenomas, you may have pituitary adenomas, pancreatic neurocrine tumor. In addition to all these tumors, you may have gonadal tumor, adrenal tumor, and reproductive gland tumor. Okay, renal tumor and thyroid tumor. If these tumors are there, along with pituitary, parathyroid, and pancreatic neuroendocrine tumors, then you will have to think more in terms of MEN4 syndrome. And it's usually associated with CDKN1B mutations. Not, it's very, very rare. Okay. So this is about MEN syndrome. So MEN syndrome, always go and do a revision again and again. Remember every syndromes with lot of mnemonics. You will have to remember a lot of mnemonics each and every time. So moving on to the MEON syndrome. So MEON is multiple endocrine and organ neoplasia. So along with endocrine tissues, you may also have other organs involved. So these are all the MEON syndromes. You have 6 MEON syndromes, common MEON syndrome. So one is hyperparathyroidism, Jar tumor syndrome, von Hippel-Lindau syndrome, Carney's syndrome, Cowden syndrome, McCune-Albright, and neurofibromatosis type 1. Only NF type 1, not NF type 2. It's also called as von Recklinghausen disease or Watson disease. Okay, so first one is hyperparathyroidism Jar tumor. So the problem here is in hyperparathyroidism Jar tumor, the main issue would be a parafibromin gene. So it's an autosomal dominant mutation. It's chromosome 1q, and the tumor, the main hero here would be, villain here would be parafibromin gene. So usually what happens is that they end up with lot of parathyroid excess syndrome. So hyperparathyroidism would be there, and mostly it would be an adenoma sort of thing. And around 15 to 20 percentage of the total adenoma will end up having carcinomas. So it's very, very riskier. And parathyroid would be torrentially higher, such that the patient may manifest with a lot of osteitis fibrocystica, lot of brown tumors also. So this is one osteitis fibrosis urtica Jar tumor, which is seen in hyperparathyroidism Jar tumors. Okay, sometimes the level will be very torrentially higher even without any Jar tumors also. I told you this is a MEON syndrome, right? So this is MEON. So apart from the endocrine part is hyperparathyroidism. Organ part is other all organ. They may manifest with Wilms tumor, renal cyst, renal hamartoma, renal cortical adenoma, renal cell carcinoma, pancreatic adenosis, uterine tumor, testicular mixer, germ cell tumor, etc. So all these things can manifest along with hyperparathyroidism. The ideal treatment is to go for an early parathyroidectomy. Okay, so usually when you suspect patients to have this particular thing, very frequently you will have to check the parathyroid levels. Okay, and if there is ossifying jaw fibroma, you will have to go use oral pantomogram, which is actually going to tell you a complete 360-degree picture of your parathyroid gland. Sorry, of your jawbone. And 5 years once you can do a abdominal MRI, because most of the tumors would be concentrated in your renal division only. So you will have a renal cyst adenomas, renal cortical cyst, or it could be renal clear cell carcinoma or something above your brain, like Wilms tumor, neuroblastoma could be there, renal hamartomas could be there. So most of the time would be like below the pelvis one, uterus, pancreas, testes, everywhere would be involved. So uterine also, annually you can go for an ultrasound screening. So because in uterus you may frequently land up having uterine tumors. Okay. Von Hippel-Lindau syndrome is something which is also autosomal dominant, and it is 3P. I have explained you about von Hippel-Lindau syndrome in pheochromocytoma session. I have told you about there are two types of von Hippel-Lindau type. We have got type 1 and type 2 based on the expressibility of von Hippel-Lindau. If minimal expression of von Hippel-Lindau is there, no expression is there. So minimal level, no expression is there, no risk of pheotom. Minimal expression is there, definitely all will manifest with pheo. Okay, again in 2, you have 2A, 2B, 2C. It's beyond the scope of this particular session. But you just know that the problem here is von Hippel-Lindau gene is actually a tumor suppressor gene. So it's going to produce a product called elongin, which is going to suppress your vascular endothelial growth factor and hypoxia inducible factor. So what if adequate suppression is not there, they go for an unrestrained proliferation and angiogenesis. So lot of new blood vessel formation will start taking place. So there would be retinal angiomas. So once retinal angiomas are there, what will happen? Automatically, because of the constant pressure in the vessels, and they are neogenesis vessels, so they will be very fragile. So they will leak protein. So there will be a lot of exudative retinal detachment may happen. So blindness can happen. So in one hemophilia. The second thing is that they may present with hemangioblastomas. So it could be a spinal hemangioblastoma, cerebellar hemangioblastoma, and usually retinal hemangioblastomas are also very, very commonly seen. Okay, and with respect, this is about the angiogenetic part. With respect to the HF-induced other manifestation, pheochromocytomas and paragangliomas would be very commonly seen. Okay, and tumorogenetic part is also very commonly seen. You could see cystadenomas everywhere. So pancreatic cystadenoma, you can renal cystadenoma, which is usually papillary cystadenoma. Of ovaries also you can see. Broad ligament, you can see cystadenomas of broad ligament. Endolymphatic sac tumors could be there. So all these things are manifestation of VHL gene. So lifetime risk of renal carcinoma, clear cell carcinoma, usually would be 70% in VHL. So that is very important. So they manifest with hemangiomas, hemangioblastomas, retina cysts in pancreas, kidney, and epididymis also. So what do you see? Cerebellar hemangioblastoma, retinal hemangioblastoma, endolymphatic sac tumor, spinal hemangioblastoma, adrenal pheo and paraganglioma. Pancreas could be cyst or neuroendocrine tumor also. Serous cystadenoma, kidney cyst and renal cell carcinoma with the very high risk of malignancy. Okay, and epididymis also you can have papillary cystadenoma. So this is about VHL. So whenever VHL is being asked, four things should come into your mind. One is increased expression of VEGF and HIF. Once this comes in your mind, automatically you will tell all the other manifestations. And HIF, if it comes, pheo will come, paraganglioma will come. VEGF, it comes, lot of hemangioblastomas, angiomas will come. So what are all the things? And cystadenomas can also be very commonly seen. Okay. So this is about VHL. The third important thing is Carney's complex. So Carney's complex is also autosomal dominant sort of mutation. Here the problem will be protein kinase receptor A regulatory 1 alpha subunit. So here 1 alpha subunit, which is actually a regulatory subunit, which will be regulating the cyclic AMP levels. Protein kinase cyclic AMP levels is being regulated. Okay, so because of this functions like a tumor suppressor gene. Once it goes for a mutation, unrestrained cyclic AMP production would be there. So it's more like without a ligand, your receptor will be activated downstream. So a lot of activity will go downstream of receptor without a proper ligand. Okay, so they usually manifest with. Remember Carney as a girl. Okay, so for a girl, what are all the common important thing that you will see? The skin. Okay, so lot of lentigens will be there. Okay, so lentigens or you may have a blue neve. So these lentigens, lot of myxoma would be there. So myxoma would be in the skin, it could be in the GI tract also. So it could be everywhere. This myxoma would be in the heart. Okay. Okay. And for a girl, what are the other important features? She needs a male. So sertolizal. Remember sertolizal. For a girl, she needs proper puberty. So ovaries, thyroid, and somatotrope manifestations can be there in Carney's complex. And the utmost importance is PPNAD. This we have seen in Cushing's. Primary pigmented nodular adrenal disease. It is very, very common in Carney's complex. So usually the Cushing's, which happens due to the primary pigmented nodular adrenal dysplasia, will be a periodic Cushing's or cyclic Cushing's. So they may not manifest with typical clinical feature of Cushing's syndrome because it is coming on a cyclical basis. Usually clinical features won't be there. They will have a thin phenotype. So this is about Carney's syndrome. Again, in Carney's there are two types, 1 and 2. Chromosome 17q, 1, 2p is 2. This is about Carney's complex. Okay. So in Carney's complex, remember a girl's name. So you will be able to remember all the other manifestations. For a girl's skin is very important. So antigens, blue neve and all you remember. Myxoma you remember. Heart is important. So neve, atrial myxomas could be very common. The plop sound, which is common in heart myxomas, usually happens in Carney's complex. And apart from that, ovaries, thyroid, and male is important. Sertoli cells is very important. Growth is very important. Even some skeletal manifestations can be seen in Carney's complex. Okay, and PPNAD, which will produce cyclical Cushing's, is also very common in Carney's complex. So this is a Meon syndrome. So what is endocrine manifestation here? We are having a lot of thyroid, somatotrope, sertoli sort of manifestations here. The organ manifestations would be generally myxomas and other renal tumors, which may happen in Carney's syndrome. So for a Cowden syndrome, it is again Cowden. Just remember den as 10. So usually it's chromosome 10 mutation, P10 mutation. So phosphate and tensin homolog. So this is again more like a tumor suppressor gene. If it goes, there would be unrestrained RAS activity. So RAS is very important for mTOR pathway as well as MAP kinase pathways. So all these are tumorogenic pathways. So once RAS is upregulated, it usually will be downregulated with P10. If it is mutated, RAS pathway will be upregulated and there will be a lot of tumorogenesis. So for Cowden syndrome, I usually remember a cow. The cow, how to draw a cow? It will have a big head, right? So it will have 2 ears. So I remember hamartomas for the 2 years. Big head, so macrocephaly. A large jaw would be there. So osteoitis fibrosa cystica. And cow will have a very low IQ. So they will have my mental retardation. Okay. So it will have a large jaw, which will be like a papule. So a lot of papillomas would be there in the cow. So the cow will have a belt in the neck region. So I remember thyroid for that. So in thyroid, a lot of carcinomas are very common in Cowden syndrome. The carcinomas in thyroid will be papillary thyroid and follicular thyroid carcinoma, and usually it will be a differentiated sort of carcinoma. Around the incidence of carcinomas will be around 50% of thyroid carcinomas will be there in Cowden syndrome. And cow has sorry for the picture. I'm very poor in drawing. The cow will have a very strong legs. So remember acral keratosis. The cow will have a lot of black patches here and there. So the cow will have melanotic schwannomas. This melanotic schwannomas can be even seen in your GI tract also. If a lot of schwannomas is seen in your GI tract, then automatically they'll end up similar to papillomas only. Obstipation, constipation, diarrhea would be there. And cow will have teats. So remember breast carcinomas. So breast carcinomas usually would be fibrocystic disease or adenocarcinomas. Okay. So fibrocystic disease or adenocarcinomas would be there in breast. And remember the gut. So in gut also you will have ganglioneuromas. GI ganglioneuromas would be there. Remember the uterus, cow as giving birth. Endometrial CA would be there. So this is the general mnemonic that I use for Cowden syndrome. I'll just come again with those mnemonics for easy understanding. Remember a cow to have a very large ear. So cow will have hamartomas, large head, so macrocephaly. Cow will have low IQ, so my MR. It will have a large jaw, so automatically osteoitis fibrosa cystica. And this looks like a papule, no? So papillary lesions, a lot of papillary lesions would be there. And the cow will have strong legs, so acral keratosis. It will have a bell. Remember thyroid, so thyroid CAs. It will have endometrium, so endometrial CA. Patches here and there. Melanotic patches, so melanotic schwannomas could be there. It has a teat, so breast CA. And it will have intestine. So imagine GA ganglioneuromas. So these are all the manifestations in Cowden syndrome. So Cowden, remember chromosome 10 and P10. So this is about Cowden syndrome. So everything will harbor around it. So you have mucous membranes, hamartomas lesion, buccal, intestine, colon, thyroid. There can be multinodular goiter or follicular thyroid cancer. Breast, there can be fibrocystic disease or adenocarcinoma. So what you see here is papillomas, small papules. You could see the cobblestone appearing papules here also in the even in the tongue also. So all these are manifestations of Cowden syndrome. Again, Cowden syndrome is of multiple types. You have even seen STH B and D happening with Cowden syndrome. So just remember one, just Cowden syndrome 1, which will be P10 mutation, chromosome 10. Okay. So moving on to McCune-Albright syndrome. So McCune-Albright syndrome, the common thing in McCune-Albright syndrome, how it stands away from other syndromes is that McCune-Albright syndrome is not a germline mutation. It usually happens right after a zygote is being formed. So it is a post-zygotic mutation, and this it is a somatic mutation. So it's since it happens right after a zygote is formed in particular somatic line, this is going to exhibit mosaicism. Not all cells are affected equally. Only certain groups of cells would be affected. So they have mosaicism. Clear? So the triad you will have to remember. You have triad and McCune-Albright. The classical triad and McCune-Albright syndrome would be Cafe-Au-lait, fibrous dysplasias, and the third important thing is gonadotropin independent sexual precocity. So the problem with McCune-Albright syndrome is about the GNAS gene. So this is GS alpha. You have seen the G protein coupled receptor, no? So just down beneath the G protein coupled receptor, you will have the GS alpha, GA, GQ, and all. If there is activating mutation in GS alpha, without the receptor getting activated, it's going in for a spontaneous activation. So ligand independent activation sort of features would be there. So usually, if it happens in dermal melanocyte, they manifest with cafe-au-lait lesion. Usually, you remember coast of main appearance, M for M. So coast of Maine is usually seen in McCune-Albright, M for M. Okay. Coast of California would be seen in neurofibromatosis type 1. So M for M. M, if you M is irregular, no, it's more like an irregular thing. So usually M, coast of Maine appearance would be an irregular cafe au lait. And it will be very, very larger. And this usually doesn't cross your midline of your body. Caffeolation never crosses the midline of your body. Clear? So this would be C. The second thing is fibrous dysplasia. So it can be anywhere. It would be near facial fibrous dysplasia, or it could be near muscles. It could be near arms, or it could be near legs. Sometimes it could be near spine also. So the problem with fibrous dysplasia going on loosening. So there will be a very high risk of pathological fractures. And GISP, gonadotropin independent sexual precocity. It's due to the normally what happens, FSH and LH would be stimulating your ovaries, right? Normally with FSH stimulation, what happens, your ovary will start producing follicles and a lot of estrogen will be produced. LH stimulation, your ovaries will produce from this granulosa cell, estrogen will be produced. And finally, when it turns into luteal phase, it will be producing progesterone. The problem in the McCune-Albright syndrome is that in the ovaries, the FSH, without FSH, the FSH receptor would be stimulated. So a lot of oocytes will start forming and a lot of estrogen would be there. So as a child, right, within 1 or 2 years of the age, the child, if it's a girl child, what will happen is that this high estrogen will start the child to develop small breast and uterus will enlarge and the child will have isolated menarche. So isolated menstrual bleed would be there. Okay, there should be adequate HPA access for a proper ovulation to occur, for a proper progesterone formation. Only if ovulation occurs, progesterone would be formed, right? Because it needs luteinization. So here only estrogen would be higher. Because of estrogen, high estrogen, there would be isolated menarche if it is a female. If it is a male, the testis would be stimulated. So seminiferous tubules will start enlarging. So there will be irregular enlarged testis. And spermatogenesis may also sometimes happen. Sometimes it may happen because of the intratesticular testosterone levels, there may be small spermatogenesis happening. So this is the classical triad in McCune-Albright syndrome. But apart from your reproductive endocrinology, the other endocrine glands can also be involved. For example, if you take pituitary, sometimes it will go for spontaneous hyperplasia. And without any adenoma visible, the patient may present with acromegaly, Cushing's and all. Okay, because the particular cell will go for a stimulation. And similarly, if it is a thyroid, like TSH receptor negative, uh, like hyperthyroidism could be seen in thyroid also. Adrenal, sometimes Cushing's, adrenal hyperplasia and Cushing syndrome like features can also be seen in McCune-Albright syndrome. So this is about McCune-Albright syndrome. Generally, it's a somatic mutation, post-zygotic mutation, mosaicism. This is about a cafe or lesion, how it's not crossing the midline. You could see the irregular border. This is called as coast of main appearance. This is yet another which is not crossing the midline. This is yet another which is not crossing the midline. Okay. And what you see here is a fibrous dysplasia and this patient is having scoliosis. Okay. So triad is KFLA, fibrous dysplasia, and gonadotropin independent sexual precocity. And the patient may also manifest with thyrotoxicosis, somatotropic tumors, and Cushing syndrome. So I am telling you everything in terms of endocrine manifestation. Where is the organ neoplasia here? Sometimes these patients may manifest with other sort of organ neoplasias also. So there could be a thymic tumor, there could be other thyroid tumors, bone, especially bone also may here. So fibrous dysplasia, if dysplastic fibroblast usually secrete a lot of FGF23, which is also called as phosphatonin. So it literally means it is a phosphatonin. So it is a phosphaturic factor. It's going to excrete phosphorus. So this is going to be a hypophosphatemic rickets. This is going to cause a hypophosphatemic rickets, and usually it will be vitamin D resistant. If you are giving the patient, usually will have manifestations of rickets, but generally any childhood rickets we tend to treat with vitamin D because mostly it will be vitamin D deficiency. But in this case, it would be a vitamin D resistant rickets. It is due to the elevated FGF23, which is coming from the fibrous dysplasia in McCune-Albright syndrome. So one more important factor in McCune-Albright syndrome is that usually the children would be pumped with lot of estrogen. So if it is left uncontrolled for years together, the hypothalamo pituitary axis would be primed with estrogen. So what happens is that when you suddenly stop the patient's estrogen, like you are giving the patient, treating the patient with some estrogen antagonist, the patient's, the girl child's estrogen is already higher, very, very higher. The HPG axis is already primed. Okay. So now what you're doing is that if the testo is higher, what you do is that you're giving something which is going to act against and prevent these manifestations. So you're going to give a estrogen antagonist. Okay, or you are going to give something called as testolactone, which will prevent the conversion of testo to estrogen, whatever it is. You are arresting the peripheral precocity. What happens due to the sudden fall of estrogen and testosterone? Your feedback axis would be activated, and this will slowly getting converted to gonadotropin independent precocity. Will be slowly converted to gonadotropin dependent precocious puberty. So this entity can happen. If it happens, then you will have to treat it with GnRH analogs. You will have to treat it like central precocity, and you will have to treat both central as well as peripheral precocity. So both the treatment should go on simultaneously in McCune-Albright syndrome. Okay, so that can be asked as an MCQ. So moving on to the next thing, the last one in beyond syndrome would be neurofibromatosis. So neurofibromatosis, always remember, there is around NIH, there is a criteria called NIH criteria in neurofibromatosis. So out of 6, at least 2 should be positive to tell that the patient is having neurofibromatosis. So autosomal dominant condition, the problem lies in neurofibromin gene. It's also called as von Recklinghausen disease or Watson disease. Okay, in neurofibromatosis, what are all the six categories? The first thing is in skin, what they should have. They should have KFLA. The second thing, they should have neurofibromas or plexiform neurofibromas. Okay, plexiform neurofibroma, and they will have freckling. So this is called axillary freckling. You could have small freckles here and there. What you see is actually the KFLA macules. KFLA macules. Okay, so this is the neurofibroma. This is plexiform neurofibroma. You see the entire nerve branch flexed up with a lot of neurofibromas. So it's plexiform neurofibromas. So in skin, you have 3 manifestations. In eyes, you have 2 manifestations. One is the Lisch nodules, and other one is optic glioma. So you have 1, 2, 3, 4, and 5. The sixth one is skeletal manifestations. Okay, in skeletal manifestation, what you may have? So you may have features of pseudoarthrosis tibia, osteoporosis could be there. Generally, intracortical thickening could be there. Thinning would be there, sorry. Sphenoid dysplasias could be there. Because of all these, the child may be born with a very big head. So macrocephaly, MBAR, like mental retardation, seizure could also be manifestations. Okay. So generally, the osseous manifestations would be seen less than 1 year because the child starts to grow, starts to expand to the maximum in the first year of life. So osseous manifestation would be usually seen less than 1 year. The child's neurological development will be maximum until 3 years. So the neurological manifestations like seizure and other optic gliomas symptom feature will occur somewhere between 1 to 3 years. And usually the other skin manifestation will appear above 3 years only. So, in fact, cafe au lait lesion and neurofibromas, initially it will be very lesser, but usually as age advances, you could see that neurofibromas coming more and more. That happens usually once they cross their childhood only. So these are all the manifestations, and out of these manifestations, at least two should be there. Cafe au lait, at least how much should be there? More than or equal to 6 cafe au lait should be there. If they are pre-pubertal, the size should be more than or equal to 5 mm. And if they are post-pubertal, the size should be more than or equal to 15 mm. So of this, at least six should be there to call them to at least satisfy the criteria of a neurofibromatosis type 1. Okay. And the cafe au lait lesion would be usually it would be called as coast of California appearance. It would be smooth borders, if you see. Can cafe au lait be seen in a normal person? Yes, it can be seen in normal persons. In around 10% to 15% of normal individuals also, you can see cafe au lait, but at least it will be 2 to 3 only, not more than 6. Okay, so neurofibroma, at least two neurofibroma should be there, or one plexiform neurofibroma should be there. Okay, similarly, list nodules are usually seen in the eye. List nodules. You will have to see a slit lamp examination to differentiate it from an EY. And list nodules, at least two or more nodules should be there. An optic glioma, at least one optic glioma. Mostly the optic glioma in neurofibroma would be intracranial only. It would be usually seen in intracranial portions. Skyphosis, scoliosis, other all skeletal manifestations, deformities can also be seen in neurofibromas. Okay, so these are all the neurological manifestation. Peripheral and spinal neurofibroma, optic glioma, iris hamartoma, which is called as Lisch nodule, dermatological cafe au lait lesion could be there, skeletal scoliosis, macrocephaly, short stature, pseudoarthrosis, mostly pseudoarthrosis tibia would be seen. And they may present with pheochromocytoma. And neurofibromatosis type 1 is the only condition which may present with endocrine manifestation, which is pheochromocytoma. Neurofibromatosis type 2 is otherwise called as schwannomatosis. So usually they'll have bilateral vestibular schwannomas or unilateral vestibular schwannoma with other nerve sheath tumor, but they will never have endocrine manifestation. So NF2 is not going to come under beyond. NF2 is not going to come under beyond. Only NF1 is seen under beyond, and the manifestation would be pheochromocytoma and carcinoid syndrome. And sometimes precocious puberty can also be seen. Why precocious puberty is seen? It is not due to the endocrine cells, but rather it is due to the gliomas, which ependymomas or meningiomas, which will directly irritate or compress your hypothalamus. And due to the constant stimulation, your kiss peptide would be increased, and thereby you may have precocious puberty. Usually it will be central precocious puberty. Neurofibromas. Okay, and the hypertension would be a vascular hypertension, or sometimes it could be due to the pheochromocytoma also. This is about neurofibromatosis. Clear? So beyond syndromes, you have to know about all 6 syndromes in detail. What is neurofibromatosis? Micule-Albright, Cowden-Carney syndrome, and the other two like hypothalama, jaw tumors, and what else I have left? Von Hippel-Lindau disease. Okay. So moving on to the final section, which is autoimmune polyglandular syndrome. Again, as the name tells you, autoimmune polyglandular syndrome is again of 4 types. Just like in MEN1 syndrome, there are 4 types of autoimmune polyglandular syndromes. You have APS 1, 2, 3, and 4. So anything which is not fitting into 1, 2, 3 will come under APS 4. But APS 1 has to be differentiated from APS 2. I will just lay out the common features. APS 1 is generally seen in infancy. The onset would be infancy. Usually it is seen in adulthood. It is autosomal recessive because it manifests as early as infancy, right? So here it would be usually polygenic. Okay, so it would be polygenic. There should be some HLA-DR3 or 4 polymorphisms, or sometimes due to certain other mutation like PTPNG mutation would be there, or CTLA4 mutation, or sometimes VNTR mutations, MICA gene mutation. All these mutations are T cell regulatory genes mutations. So there would be some problem with the T cell regulation and thereby the autoimmunity. So it would be usually polygenic inheritance. Clear? So APS1 usually will have a classical triad. At least 2 out of 3 should be positive. Just remember this mnemonic. So this is called PACA. Just remember this mnemonic. Okay. Here at least 2 out of 4 should be positive. Remember the mnemonic GAGD. So PACA is hypoparathyroidism. Hypoparathyroidism. C for cutaneous or candidiasis. Cutaneous or mucocutaneous candidiasis. Okay. A for adrenal insufficiency. These are all the classical things for APS1. Here you will have to remember G for hypogonadism, A for adrenal insufficiency, G for Graves, and D for type 1 diabetes mellitus. Okay, so out of these four, at least two should be positive to call it as APS2. Okay, so apart from that, you have to remember yet one more mnemonic. You remember PAR tag, here you remember P tag 3D. Okay, hypoparathyroidism, autoimmune thyroiditis, adrenal insufficiency, and hypogonadism. These are all the other manifestations. So hypopara we have told, hypothyroidism we have told, adrenal insufficiency we have told, grades. Okay, here you will have to remember hypopituitarism, hypothyroidism, or any sort of thyroid disorder, adrenal insufficiency. 3G is there. So one is Graves, other one is hypogonadism, the other one is myasthenia gravis. And D is diabetes mellitus, mostly type 1 diabetes mellitus. Okay, and type 1 you will have to remember about the appendages. All the appendages will be affected because the type 1 I told you it is autosomal recessive mutation. It is due to it is also called as APS syndrome, autoimmune polyendocrinopathy, okay, cutaneous candidiasis, and ectodermal dysplasia. So this is the entire expansion of APS syndrome. Okay, the problem would be in chromosome 21 usually. Most likely, this would be a familial thing, but it could be de novo. 50% could be a de novo mutation also. Both male as well as females, they are equally affected here. But here, female will have more predisposition. Here, female will have more predisposition than males. You know the reason, right? Okay. Similarly, the problem here is autoimmune regulator element. So because of this dysfunction, ectodermal dysplasia is also very common because of the immunological dysfunction. So what are all the appendages involved? In skin, what problems can be there? In skin, you may have vitiligo. I told you about candidiasis also. Okay. In mucous membrane, what you may have? You may have thrush, candidiasis, you may have. You will have severe mucositis, so stomatitis, angular cheilitis, everything would be there. And the same mucosa in your GI tract can be involved. So they may manifest with celiac disease, pernicious anemia, and other sort of malabsorptive features could be still be there. Okay, this is about the mucosa. And with regard to nails, you may have nail dystrophy or nail dysplasias. Okay, with regard to hair, you will have to remember about alopecia. Okay, and with regard to bone, you will have to remember metaphyseal dysplasia. And in tympanic membrane also, you may have tympanic membrane calcification. Muscles, you may have certain type of myopathy also. So musculoskeletal manifestation can still be there. All the appendages would be involved. Okay. So these are all the manifestations that we generally tend to get in APS type 1. So here again, there may be vitiligo, but there may not be candidiasis. Again, mucositis, celiac, pernicious anemia can still be there. There won't be any nail manifestations. Hair manifestations can be there. So all these things like myopathy or bone involvement won't be there in APS type 2. So this is the major difference between APS type 1 and APS type 2. So just know about it so that it will be easy for you to diagnose and go about it. In APS 1, I told you it is due to the autosomal recessive mutation and the manifestation can happen as early as infancy. So the first and characteristic manifestation would be CMC, chronic mucocutaneous candidiasis. So it will manifest as younger as 1 year of age. So less than 1 year of age, it will be recalcitrant, recurrent candidiasis in this patient. So that is of utmost important. Followed by adrenal insufficiency. So that comes until 5 to 6 years. You may manifest with adrenal insufficiency. Only later they will manifest with hypoparathyroidism. So this is the general dictum of manifestations. So generally, the antibody here is anti-interferon gamma, omega and gamma. That would be 100% present in all these individuals. Okay, but along with it, they may present with chronic active hepatitis also. That is very important. Here they may present with ITP. So they may present with ITP and other sort of hemolytic anemias. One more important thing is this AARE element is extensively expressed in lymph node, spleen, and thymus. So there would be a lot of immunological dysfunction happening in these individuals to the extent 20% may be present with A splenia also. So they will have recurrent infections. Those capsulated organisms, they will recurrently attack these type of persons. So this is about APS1. The basic thing is they will manifest in infancy, AR mutation. It's also called epicate syndrome. You have AARE gene mutation, chromosome 21 is involved. Remember about the classic triad PACA, and you will have hypoparathyroidism, mucocutaneous candidiasis, and adrenal insufficiency. If at least two out of these three is present, you can tell it as APS1. Remember the part and what are the other manifestations. And regarding the appendages, skin, mucosa, nail, hair, bone, TM joint, and muscle. Apart from that, you will have chronic active hepatitis also. So because of the lymph node, spleen, and thymic involvement, sometimes mediastinal enlargement, lymph node enlargement can be seen. And on longer run, they may cause obstructive airway disease and pulmonary artery hypertension. Very, very rarely they present with this thing also, like idiopathic interstitial lung disease can be a manifestation also. As against, this thing usually manifests in adulthood after 20 to 30 years and more commonly seen in females, and it has got a polygenic inheritance. You have to remember about the basic request is out of these four, if two is present, you can call it as APS2. So the basic thing is if you are having an adrenal autoimmune hypothyroidism along with adrenal insufficiency, you call this condition as Smith syndrome. In a Smith syndrome, if you have type 1 diabetes, you call it as Carpenter syndrome. These are all just named syndromes you will have to know. Okay, but again, they may very well fall into APS2 category. So along with that, like PATAC here, PTAC 3D is there. The third three would be Graves' disease. P is hypopituitarism. Okay, and they may not have candidiasis and nail dystrophy. Okay, and ITP and hemolytic anemia is a bit common in APS type 2. So this is about APS type 1. I have told you about it. So you will have diarrhea, ectodermal dysplasia, hypoparahepatitis, chronic active hepatitis, hypothyroidism or Graves, male hypogonadism, malabsorption could be there. I told you the reasons for that. Mucocutaneous candidiasis, obstipation would be there. And ovarian failure. Obstipation is mainly due to low calcium. Okay, ovarian failure would be there. Again, and pernicious anemia, splenic atrophy, asplenism. Okay, type 1 diabetes. So these are all the manifestations. You have keratoconjunctivitis. I forgot to mention, among the mucosa, you can have keratoconjunctivitis sicca. This is the thrush. This is mucocutaneous candidiasis. This is nail dysplasias. Alopecia areata. Did I mention about hair? Yeah. Alopecia areata. This is vitiligo seen in the knee. And these are the rashes. Sometimes infants may manifest with non-specific rashes. So the febrile rashes would be there in infancy. So usually the treatment for these rashes would be high dose of steroids. It would be immune-induced rashes. Okay. So extreme variant of this syndrome is called as IPEX syndrome. So you will have to know that is a separate disorder. It's not under APS1. IPEX syndrome is an X-linked recessive syndrome due to the FOXP3 mutation. So it's a main important immune regulator. So because of that, there will be immunological compromise. So just expand the IPEX, so there will be immune dysregulation. So these patients may manifest with very florid immune dysregulation to the extent that they may present with life-threatening leukemias and lymphomas also. Okay, P is polyendocrinopathy. So you have a lot of endocrinological features here. The main important is type 1 diabetes-like feature, which is called as acute fulminant diabetes. It is immunologically mediated, sometimes without antibodies. Less than 6 months of age, they may manifest. Okay, so polyendocrinopathy, X-linked syndrome. E for enteropathies. So they may present with life-threatening diarrhea and severe dehydrations. So this is actually called as IPEX syndrome. So initially, if they are given proper, if they are duly diagnosed and adequately treated, they may easily escape their infancy easily, and they may survive their adulthood. Okay. So with respect to the APS2, I told you about all the mnemonics. Descents would be there, alopecia, autoimmune hyperceliac, cerebellar ataxia, again due to the pernicious anemia, vitamin B12 deficiency, and folate deficiency. Because of that, you may have cerebellar ataxia. CADP, neurological manifestations are very common in APS2 than APS1. So this is one standalone feature. Neurological complications are more common here. Hypophysitis will happen only in APS2. Idiopathic heart block could be there. IJ deficiency, myasthenia gravis, I told you already, myocarditis, pernicious anemia. Serositis can happen because of other manifestation, be closely linked with SLE, Sjogren's syndrome. Adult onset, right? Stillman syndrome and vitiligo. Okay. So when you compare early onset, later onset, siblings often affected and they are at risk. It's multi-generational, equal distribution. Females are affected. ARE gene, chromosome 21, you have all these genes here involved. It's not HLA related. It is predominantly associated with HLA polymorphisms. You have antibody to interferon gamma and omega, and you have other interleukins affected here. Here there won't be no antibodies to the cytokine elements. We have the autoantibodies to specific target organs. Asplenism is very common here. Mucocutaneous cancer is a standout feature here. Here we have myasthenia gravis. You have idiopathic thrombocytic purpura. You may have immune-mediated neuropathy manifestations. So these are all the characteristic features in APS2. Okay. So you have APS3. So when you are having autoimmune hypothyroidism or autoimmune thyroid disorder, hypo or hyper, plus anything which doesn't fit into this PACA, no hypopara, no candidiasis, and no adescents, then you call it as APS3. Anything which involves two or more glands, endocrine manifestations, which is not fitting into APS1, 2, or 3, is called as APS4. So this is the basis. Yeah. I've told you about Carpenter and Smith syndrome also, and you will have to know about IPEX syndrome also. So yet other varieties or anti-insulin receptor antibody. This is called as type B insulin resistance. You have insulin resistance usually has three types. You have type A, type B, type C. Type A is when there is some problem right at the level of your insulin receptor. So insulin receptor would be at the problem, either in the receptor A subunit or B subunit or downstream to receptor. There is an intrinsic problem with the receptor, which is usually genetic. So there would be a germline manifestation. You call it as type A mutation, type A insulin resistance. To call something as type B, their insulin receptor would be intact, but there would be something else which is blocking the receptor, so that is not able to act, and that is insulin receptor antibodies. So this is otherwise called as anti-insulin receptor antibody syndrome or type B insulin resistance. Usually it's associated with SLE or Sjogren's syndrome. So there will be a lot of insulin production, but it may not be able to act at the level of the receptor because these antibodies are blocking the receptors. Okay. Type C is whenever there is some post-receptor mutation or post-receptor changes. It commonly seen with our obesity and metabolic syndrome. Because of excessive cytokines, there would be post-receptor defect or certain genetic mutations with the post-receptor defects. So that can manifest as type C insulin resistance. So anti-insulin receptor antibody, 2/3 is associated with SLE and Sjogren. What will happen automatically? A lot of insulin is there. It's not able to act at the level of insulin receptor. So it will act on IGF-1 receptor. So acanthosis nigricans would be there. Hypoglycemia would be there. And hyperglycemia at later stages, because initially it would be high insulin levels. Later on, what happens? It will go for hyperglycemia. It will exhaust itself. High ESR, hyperhemoglobin, leukopenia, thrombocytopenia because of autoimmune etiology. Marked insulin resistance requiring more than 10,000 unit of insulin may be there. Severe hypoglycemia could also be a manifestation, and the disease course is variable. So you will have to target the autoimmunity here. So what you do is that you're going to give some targeting agents for the B lymphocytes. So ideal thing is rituximab, cyclophosphamide, IVIG, and pulse steroids, etc. So these are all the treatment therapies available for type B insulin resistance. Hirata syndrome is something when you have anti-insulin antibody. You will have to differentiate anti-insulin receptor antibody from anti-insulin antibody. So the problem here is you have insulin, you have a lot of sulfhydryl disulfide rings, sorry, disulfide linkages and sulfhydryl groups. So if there is anything which is similar to an insulin molecule, or due to some other reason there is a molecular mimicry, and it is now counteracting with your insulin in form of anti-insulin antibodies. You call it as Hirata syndrome. So it could have been mostly some antibiotics with the sulfhydryl groups, or something like methimazole, or Graves disorder, where you have a lot of anti-insulin antibody in Graves disorder directly. Okay, or methimazole therapy, which has sulfhydryl groups, and it will actually cross react with your body and produce a lot of anti-insulin antibodies. So the problem here is these anti-insulin antibodies would be produced in plenty. So they will go and bind with the insulin levels. So it will not allow the insulin to act. So initially your body will sense that there is no insulin at all because it's not acting. So body will produce lot of other insulin. So insulin will be produced after a certain period of time. What this antibody does is that it will leave this insulin and it will be disappearing. Now, instead of initially 4 units of insulin are produced, because they are bound to antibodies, the body senses insulin deficiency and it's producing 40 units. By the time 40 units is produced, these antibodies will leave these 4 units and go away. So now the total unit would be 44 units, and this will suddenly bring you a hypoglycemia. So this happens in Hirata syndrome. So this is what we call it as anti-insulin antibody syndrome. Usually it's associated with SLE and autoimmune condition, but rarely it is associated with lymphomas also. So it is due to some HLA polymorphism condition. Sometimes this could be life-threatening also. The treatment would be to initially identify the underlying cause and treat it, but until then you will have to suppress the antibody production. So you are giving high dose of glucocorticoid or rituximab therapy. So this is about Hirata syndrome, anti-insulin antibody syndrome. So the next thing is Crowe-Fuke syndrome. So it's also called as POEM syndrome. So polyendocrinopathy, organomegaly, and you will have a polyneuropathy, organomegaly, endocrinopathy, myeloma, and this is for sclerotic lesions, I think, sclerotic bony lesions. So you will have all these things put together in the same patient. The basic problem is a light chain myeloma or a plasma cell dyscrasia in any form. Okay, it could be usually a monoclonal gammopathy or some myelomas. So because of that, what will happen? There would be a paraneoplastic manifestation. It will start to produce a lot of VEGF and other cytokines. Because of the vascular endothelial growth factor, there will be and other cytokines which are being secreted by this myeloma. There will be a lot of progressive sensory motor polyneuropathy. Okay, and this will also affect and cause you diabetes, primary gonadal failure, and other endocrinopathy could be there. And because of the immune mediated changes, there could be hepatomegaly, splenomegaly, lymphadenoitis in these patients. So hyperpigmentation is usually VEGF induced. So usually it manifests by fifth to sixth decade. It's very difficult to diagnose it because the index of suspicion is very, very lesser. So the once it is diagnosed, you can go for thalidomide, lenalidomide, dexamethasone. But the ideal treatment of choice would go for an autologous stem cell transplantation in this patient. So the recurrence rate is also quite higher in POEM syndrome. So the POEM syndrome is otherwise called as Crowe-Fuke syndrome. All these syndromes I have seen in my residency. These are all very rarer syndromes, but again, the suspicion should be very, very higher whenever we see patients with multiple other manifestations. Okay. So IPEX I have discussed already. It's X-linked recessive, FOXP3 mutation, infant onset. The child will have a type 1 type, it will be fulminant onset, enteropathy would be there, skin lesions would be there, like how we saw in APS type 1, there would be skin lesion, and other endocrinopathies could be there. Usually dies in a year if it's not treated, but rarely they may survive until 15 years. Stem cell transplantation is the main life-saving procedure, and before that, you will have to go for strong immunosuppression. That would be the ideal treatment of choice until the patient is being posed for stem cell transplantation. Okay. So with this, we come to the end of this MEN1 and APS syndrome. I'm just going ahead with the 4 to 5 questions here. I think we have reached our timing. Sorry. We'll finish it in the next 5 minutes, okay? So MEN2 is characterized by all. Is there anyone who can answer? Anyone there? Still listening? Dr. Murthy, Dr. Nikhil, and Begum Shehiba. Can you unmute yourself and answer? Or you can write there, type in the chat box. MEN2 is characterized by all except parathyroid adenoma, islet cell hyperplasia, medullary thyroid cancer, pheochromocytoma. Anyone there? I have not mentioned anything about 2A or 2B. It's just MEN2. What will not be there? Yes, very good. So Biha, it's correct. So in 2A, what you have to remember? You have to remember 2M and 1T. So the two M's would be medullary thyroid cancer and medulla of your adrenal. So remember pheochromocytoma. So for both men 2A and 2B, these two will be there. But this thing is parathyroid. Here, the other all manifestation will be the other 4M. So islet cell hyperplasia is not there. The next question, men 1, true, all except pituitary adenoma, parathyroid hyperplasia, pheochromocytoma, and parathyroid adenoma. Remember the three P's in men 1. What would be the answer here? Actually, it's a controversial question. If you just look into MEN1 syndrome, I would have mentioned pheochromocytoma also. Parathyroid adenoma may occur, but it's very, very, very rarer. So I think the answer should be parathyroid adenoma. But pheochromocytoma is also not that characteristic. Sometimes questions like this can come on a confusing front. That is why you will have to read again and again. So MEN2A is associated with all except again MTC, pheo, mucosal neuromas, and hyperparathyroidism. It's easy, right? In TUBs, what are the other four M's? Mucosal neuromas, marfanoid habitus, medullated corneal fibers, and megacolon. So it's in 2B manifestation. So mucosal neuroma doesn't come. So MEN1, the most common tumor is pancreatic tumor. Which is the most common tumor? Anyone here? Insulinoma, gastronoma, somatostatinoma, glucagonoma. Is it insulinoma or gastronoma? Yes, gastronomas. So this is a picture. Can you just find out what syndrome is this? Very easy, right? Shall I just brief it? Meant to be yes. Marfanoid habitus. This is pes cavus. These are all neuromas. You have got cobblestoning appearance here. You have neuromas here. Again, neuromas here. Neuroma in your lip here. Everything. This is eyelid, conjunctival neuroma, eyelid neuroma. This is megacolon. So pes cavus and other skeletal deformities are also common in MEN2 syndrome. Okay. So this is MEN2 syndrome. Okay. So with this, we are winding up this session. It was an exhaustive session for me also. My sound has gone to a lower decibel right now. I have got voice fatigue right now. So read again this chapter again and again and again. Only then you will be able to remember. And always, whenever you see cases, thank you. Always, whenever you see cases like that, always keep a high clinical index of suspicion towards your syndromic manifestations. It'll be very easy for you. So, any questions or any feedbacks, you can write that post in the chat box. I'm happy to answer. Any questions, or shall we wind up the session?